Well, good evening. From my home to yours, welcome to Doc Talks. I'm Lisa Goodman with St. Charles Health System, and I am the host for our event this evening. Tonight's topic, Have You Had the Talk, will be featuring our very own Dr. Laura Mavity, who is our clinical director of the Advanced Illness Management Program at St. Charles. Dr. Mavity has been with us since 2009 and has been really pioneering this work for the health system and for our community. So we're so pleased to have her tonight. Thank you, Dr. Mavity, for being here. Talking about end of life management is a timely topic. As our population continues to age, there is increasing talk about mortality and how we age, how we die, and that inherent struggle with that natural process of slowing down as we near the end of our lives. We Americans have a long history of placing high value on our own autonomy, and it seems that maybe we're just on the brink of grasping some control of our dying process, making it more personal again rather than medical. So, here to explore is Dr. Laura Mavity, and I'm just going to go on the record saying it. Dr. Mavity is one of my favorite doctors at St. Charles, so I'm so happy to be with her tonight talking about this. So, Dr. Mavity, I have to start with the question, what drew you to this work, right? Doctors go into medicine to protect life, to preserve life, to extend our lives. But you were drawn to a different spectrum of this circle of life, and I'm just curious why. Why do this work?
Oh, thanks so much, Lisa, for the introduction. And it's great to be with you too. It's great to be able to talk with you and everybody else about this. I get asked that question quite frequently. And in fact, when I'm working with our palliative care team here in the hospital, a lot of folks say, wow, how do you do what you do? And what drew you to this? I will admit that probably looking back, one of the things that did draw me to this is my medical career was very much colored in a hard but very positive way by my mother becoming sick with advanced stage cancer in her 40s. And she was actually diagnosed with that cancer during my very first month of medical school. And then she ended up dying when I was in my third year of medical school. And so that huge loss at a relatively young age for both of us really played a factor in my view on death going forward as a physician. As I was in training and learning and taking care of, you know, lots of different folks at different stages. And, you know, in training, we get to see every age of patient from babies to the very elderly. And as I continued through my training and chose internal medicine as my primary specialty, I did start to notice that I was different from many physicians in that I did not have as much of a discomfort in being around death or talking about it, and definitely developed a passion of trying to make sure that those patients who I'm lucky enough to get to care for, and death is never easy. It's not generally something most of us are looking forward to. But if we have some control and if we have some ability to have that natural process happen and different ways we can guide our path as we get close to the end of our life, it is a very, very special and sacred time to be invited into someone's life. And I very much appreciate that intimacy that people and their families allow us into in that very private time. So it is profoundly rewarding work to get to make sure that each person I get to work with's journey is as much in their control as it can be.
Dr. Mavity, there are some physicians out there. Dr. Atul Gawande comes to mind. His book, Being Mortal,
Mhm.
really set the stage for the conversation, at least in my personal experience, to think about death differently and my approach to it, and in fact, sort of the American uh, cultural approach to death. Do you feel like as a country and as a culture, we are evolving in terms of our relationship with death and how we think about it and how we talk about it and how we treat it? I feel like for so long, this almost aversion to talking about death was almost a uniquely American thing, because in other cultures, it is embraced more as that circle of life journey. What are your thoughts on that? Where are we at right now as a country in talking about death?
I think we are at a very interesting time in that that we as the medical institution in the United States, there are a lot of things that we as health systems and as doctors and and nurses and others, that we really influence that for people. We really influence that. And we have been raised as a specialty to try to defeat death. And there's a lot of talk about that, about how we really think about death and how hard did I battle, and this is my fight against the illness or illnesses that I'm dealing with, and that is kind of an American way. We're autonomous. We like to be independent, and a lot of us really do define ourselves about our strength and battle against a foe. We're starting to change that perspective in that I mean death is, I mean, most of us are not looking forward to dying. We want to prolong our lives as long as we possibly can, but especially as medicine has become so successful now at treating so many different things and prolonging our lives, there are many of us now who are able to and living with serious advanced illness for years. And that's all of a sudden brought this whole concept of quality of life really to a forefront. This is where now people are starting to, they have options. I can choose this treatment, I can choose that next procedure, but do I want to? In that, we've gotten so good at prolonging life. And that's where this whole, I think the American public is starting to take possession back on that part of our lives. I heard it likened to some of the movements in the 70s where the public, more so than the medical establishment, started taking the birth process back, right? This is when, hey, maybe I don't want to have my baby in a sterile room and I want to have the people I love around me. And maybe I don't want to have that machine or that kind of medicine. And I want to create this as much as I can. And I'm not sure if other people have had this experience, but nobody's birth plan ever works out. You write it and, life then happens. Well, death is a lot like that. But we are starting to, I think, as an American public, starting to say, well, I want to have a death plan. And I want to, I don't want to die in a hospital and I don't want to die in a nursing home. I want to die with the people I love around me. And yeah, life's going to throw some kinks in that. But if we start to really think about how we want it to be for us, we have, I think we're starting to take control back from the medical establishment. And I think now, us as the medical establishment, we're like, yes, we're ready to partner with you in that we can see that the very best quality care, which for decades we've said, oh, the hospital that's where the best quality care is delivered. Well, we're starting to see a lot of evidence that that's not always true. Hospitals will always serve us a great purpose in healing and severe illnesses. It's where, we go to get serious surgeries and things treated. And thank goodness we're so good at it. But as we start to change and our bodies are changing and we're living with serious illnesses, there are clearly times where the best quality care is actually not in a hospital. And the best quality care and better quality care than you can get in a hospital or a care facility might very well be at home. And so this is some of that paradigm shift where we can really start to think about and empower people to help their medical teams understand what their definition of quality of life is, so we can then partner to honor that and use that as I say this a lot as I'm getting to work with folks, is let's use that as our plumb line. Let's use your definition of quality of life. What's important to you? What brings you joy in your life? What makes your life worth living? There's our plumb line, and let's focus everything else around that.
In your experience as a physician, you interact with patients and families who find themselves in this situation. How often would you say families and patients are truly prepared? They have had these difficult conversations in advance. They know what that line is that they want to follow. Uh, is it increasingly more people who have a pretty good grasp on how they want this to go, or would you say we've got quite a ways to go yet?
I think it's getting better, but I think we still have quite a ways to go as well. Some of the more recent studies about the presence of advanced directives for a very, very sick population report like a 23% advanced directive presence in the medical charts of seriously ill patients. Um, I think that uh, in Oregon, especially, again, that I think Oregonians tend to be pretty darn independent and value quality of life a lot. And so I think we're probably better than the rest of the country here. But um, a lot of the work that I unfortunately help families with is talking with them about trying to suppose what their loved one might have wanted when none of us are really sure. And so although we're improving, that 20 some percent is a pretty low bar to improve from. So I think we still have a lot of work to um, help people start having the talk before the crisis happens.
So how do we do that? I mean, I'm in my 40s, I'm healthy, I go run, I mountain bike. I don't want to die. I don't think about death. I don't want to think about death. I don't want to talk about it with anyone. It feels like I'm inviting that possibility if I even bring it up. How do we have that conversation? Where do you start, and with whom do you have that conversation with?
That is so common. And why would we want to think about death while we're healthy and living our lives and busy? And it's the probably least attractive thing of a myriad of things you can talk about with the people you love. These conversations are what will often bring it to a head for some people is losing someone where they either had the conversation or didn't have the conversation, because that really brings it to a head. It is a profoundly different process when someone has laid out some guidelines about their wishes, where they've drawn their lines in the sand, versus a family guessing. And so if I find that people who've been through a loss like that, where someone either did or didn't, that will trigger them to have a new passion about actually, hey, this is awkward, but it's really important. We've seen some success of people taking the conversation to their families, and that's probably, and when I say family, sometimes you're blood related and sometimes you're not. So family I use as a, these are your people. These are the most important people to you. These are the people who know you best and love you best, and those are the ones you want to have the conversation with. And um, some people have decided that this Thanksgiving, we're all going to sit down together and we're going to talk about advanced directives. Everyone over the age of 18 should have an advanced directive. And the reason it, unfortunately, luckily, very rarely, tragic things happen sometimes. And the decisions in an advanced directive and the conversation that we need to be having when we're young and healthy are really about what I would want to have happen if something sudden and tragic happens to me. And the biggest concern is there's a terrible accident and I'm unconscious and I'm not expected to wake up. Those are the conversations that young healthy people should be having, and it's important to complete an advanced directive to really lay out, would I want to be fed by a tube, for how long, would that be okay with me? And it is important to have those conversations with the people you love so that they can get a gestalt and kind of understand where you're coming from. But certainly also, your healthcare provider can help you with trying to make sure that you understand what might be offered and not. as we age and our bodies start to slow down, we start to develop illnesses that are something that are initially quite manageable, hopefully, and then start to lead to a spot where we are at risk for being in the hospital. That's when advanced directives and conversations start to become more serious and need to really focus on what kinds of medical treatments are likely to be offered and making decisions about what's really okay with me and what's really not okay with me. And we find people all over the spectrum. For some people, going to a nursing home is like, that's the plumb line. That is my line in the sand. If I have care so that I need to go to one, mm-mm. For other people, it's being fed by a tube. For other people, it's being on a breathing machine, and so this is really it's profoundly individual. Most people, when we ask them about what they would want in the event of a really serious illness, say, well, if there's a good chance I'm going to recover, sure, I'm okay with having really invasive things done for me for a while. But there are a lot of subtleties to that, and there are a lot of things that are really helpful to share with the people you love about, hey, it's super important for me that I talk. If I can't communicate, that's not okay with me. Or it's super important to me that I eat, or it's super important that I walk. Like just some of those things based on what brings you joy as a human being are the kinds of things that these conversations really need to involve. And so the conversations really should be a family event. It can be, one of the family members saying, all right, everybody, it's going to be a little weird around the holidays this year, but we're going to have the talk. And then it's really important to have that talk and then to start thinking about documenting that talk and making sure that not only, so a lot of people will do an advance directive in their lawyer's office and when they're doing estate planning, and then it will live in their lawyer's office. It's really important that your primary care provider, your physician or advanced practice provider, and your nearby hospital, and really all of the people who are involved with you, all your family members, have a copy of your advanced directives too. And it's challenging when one exists, but nobody ever knew there was one. And these wishes are so vital to helping to color decisions and big decisions.
Yeah, and it seems like there's value in the family members understanding your wishes and why they are so. I'm thinking of a friend whose father had a stroke, and he had in an advance directive that he didn't want them to go to great lengths to save him. And so when it came time, he was in the hospital and they were proposing neurosurgery and they had to decline it. And he died the next day.
Yeah.
And that was hard for them. And they respected his wishes, but I'm not sure they were prepared to execute on them. And I'm not sure to what degree they had that conversation with him. So would you say that's true, and that that's part of the value in going through this process? It's not just you understanding what you want, but it's also helping the people around you understand, because really it's going to be incumbent upon them to execute those wishes and deal with the emotional repercussions of doing so.
The preparation thing, for those of us who have had those conversations with the people they love, and those people who are speaking for them, who are being their voice in that time, they will very clearly say, oh yeah, yeah, no, I know exactly what my dad wanted. I know exactly what they wanted. I know I need to honor their wishes, and I'm going to do that, but I'm not ready. I'm not prepared. And I'll tell you, when those kinds of things do come about, we're almost never ready. It's hard for us to fathom someone you love being so sick that all of a sudden they're not able to speak to their own wishes. And so, even for folks who've lived for many years with this serious illness and have been very aware of, their limited prognosis, it is really hard to get ready. But we are so much better prepared and able to process and grieve so much more healthy if we know that we're honoring our loved ones' wishes. That is just such a gift we can give the people we love.
So, Dr. Mavity, where do we get an advance directive? Do we have to go sit down and go through that with an attorney? Or can you download this and print it off the internet and fill it out and have it notarized? What is the process?
Yeah, great question. It actually, you do not have to have a lawyer to do an advance directive. You can print them off. The Oregon Health Authority actually uh, has the exact, in the state of Oregon, we have kind of a funny thing that we have a very specific advance directive. Other states around the country, most of them actually have more liberal laws around advance directives. We actually have a very, very particular one. And that is being reviewed at our state Senate currently, and there have been a lot of discussions about how to revise it to make ours more liberal in that you can use more than just one exact document. But for right now in the state of Oregon, this one document that anyone can find on the Oregon Health Authority website, if you look up Oregon Advance Directive, you can print it off, you can fill it out, and it does not have to be notarized. We it asks for witnesses to sign. And also in our advance directive, there are a couple of things about that. There's a section where you can designate someone to be your surrogate decision maker so that if you are not able to speak to your own wishes, then you pick that person. And often a lot of folks will pick an alternate as well to speak to their wishes if they're not able. And then it very clearly lays out some scenarios for you to tell your medical team what you would want or not want, including, if you're permanently unconscious, if you're close to death, if you have a serious advanced illness and you're not expected to recover. So all of these things are laid out in our advanced directive, and then you can indicate what you would like, whether you'd like artificial life support, whether you'd like to be supported by artificially administered nutrition or not. And then there's a section where you sign that after you've designated your decision makers. And then as long as it's witnessed by a couple of folks, it is legal and valid in the state of Oregon.
So get on that Oregon Health Authority website, get that document, fill it out, have your witnesses sign it, and then give it to who? Your spouse, trusted friends or partners. You mentioned medical providers. So more than one person should have this, correct?
Definitely, because if somebody's looking for it, it's an emergency and you want to have it as easily findable as possible.
Okay, great. And it also looks like it's on our St. Charles Health System website as well on our advanced illness management page. So you can find it there as well, which is great to know. I'm curious. So you work in this field. Can you give us an example without divulging any patient privacy information, of course, but give us kind of two examples of a death that you thought went really well because someone thought about it and they planned about it and they had that conversation. And then maybe an example of one that didn't.
Definitely. So, just a very general, and I'm making this up. It's not an exact patient, but this is an amalgamation of a bunch of patients I've had the honor to care for over the years. I'll say Sally is a 93-year-old who's been dealing with heart disease for the past 20 years. She had her first heart attack in her 70s and recovered really well, and has had to have some different procedures over the years and have her blood vessels worked on to open to try to get her blood flow to her heart working well. But in recent years, it's been harder and harder to fix. And her cardiologists have been trying really hard. She really values being independent. She's, despite being in her 90s, she is pretty feisty, likes to play cards with her friends, and likes to get out and walk with her small dog every day. And they've been trying to keep her heart going as much as they can. But recently, in the past 6 months, she's been in and out of the hospital. She's been in almost monthly. And when she gets out of the hospital, she's not recovering like she used to. She's finding now that she needs help to get dressed. She needs help to cook her meals, which she also used to do on her own, and she can't walk her dog anymore. and her heart condition has been declining, and she's been having conversations with her niece, who is her person. That is her one she designated as her surrogate decision maker, and she's been telling her niece, boy, when I get to that time where I really can't do those things, so where I can't be independent and I can't, walk my dog, that's a quality of life for me that's really important. And so Sally is admitted to the hospital after her niece finds her really confused, and they do some studies on her heart, and they see that her heart pump function is failing. And her niece is there at the bedside, and the medical team, shares how sorry they are that Sally's heart's been getting worse, but that they really don't have any more procedures that can help to fix this. And so, as hard as it is, Sally's niece is able to say, "We are at that point." She's been telling me for years that, this is the value, this is the kind of quality of life she would need to be independent and able to walk on her own. And she's been really failing in these past months. And now is the time that, even though she can't tell me right now because she's too sick, she would really want us to focus on her comfort. And then that leads to uh, a discharge home with hospice, and the niece gets some help with caregiving, and Sally dies 2 weeks later, comfortable in her home with her dog on her bed. That's how it goes when somebody is able to have the conversations along the way. Differently would be Joe, who's been struggling with lung disease for 20 years. His doctors have really been talking with him about concern about his lungs getting worse in these recent years, but it's been really difficult for him to talk about it with his wife and kids. And unfortunately, his wife finds him confused one morning and calls 911, and he's rushed to the hospital, and they do absolutely everything to help try to sustain his life. He's placed on a breathing machine. He's in the intensive care unit, and they can see that his lungs are really, really weak. And the medical team's really worried about his chances to have a good functional recovery again. And he never had those conversations with his wife and kids. So his wife and kids meet with the medical team over and over again to try to get the best sense of his prognosis and try to guess what he would want. There may be some of them who are like, no, Dad, he would really want to fight. And so he ends up being on a ventilator for weeks in the hospital before it becomes abundantly clear that this is not survivable, and he has a heart attack while he's on a breathing machine and then dies. That's a common scenario about how it might go for folks who haven't had the conversation, and the stress. Not that it was easy for Sally's niece, but that she's able to grieve better and easier, and Joe's family unfortunately is left with questioning: did we go too far? Did we make him suffer longer than he needed to? And that complicates our ability to grieve well and say goodbye to the people we love.
Mhm. Not to get too personal, if you don't want to answer this question, you don't have to. But you mentioned your mother dying of cancer many years ago, and obviously a lot has changed. You're a physician now, you worked in this field. Do you ever think, if I could go back, I would have done it differently with her, knowing what you know now, or no?
Yes, actually, yes. I had always had it in my mind, with her getting diagnosed with cancer when I started medical school. I always had it in my head that when the time came when she, wasn't doing well, when she was going to need help, and my dad was working, he was still in his 40s as well. I was like, oh, I'll take a year off medical school. I'll go take care of my mom. Like, that'll be really a great time. A great time. I'll tell you, my mom had different ideas about that. Like many of us who deal with cancer at a very young age, we're really, really fine until we're really not, really not, and very quickly. And so she was able to chug along and did, lots of rounds of chemotherapy. And when one stopped working, tried another, and she really was really okay. And to be honest, I think my sense that she was dying didn't really get clear to me until probably 5 days before she died. She was only on hospice for 5 days before her death, and that was like a whirlwind for me and my sister and my dad. It was just so sudden. And we knew this was coming, but we really were not prepared. And so I think we probably had some missed opportunities along the way to really pay attention and understand where she was at. Although, to be honest, I'm pretty sure my mom didn't want me to take a year off medical school and really wanted me to stay at medical school and finish that up and not get distracted by any means from doing all of that, which I'm sure brought her joy that she was able to see me be able to successfully continue my training. And so, I think that was a long time ago. That was, over 20 years ago. And I think we have gotten better as a society. And I hope that families feel more empowered to ask more questions along the way. We really, our team, when we're helping patients and families, really talk about how it's important that different people in the unit of that person's unit, their family, will want different information at different times. And that's super okay. There might have been times where I would have wanted to ask my mom's oncologist, so where are we? Like, what is her prognosis? And I didn't feel comfortable at all asking that. And that might have been a time that my dad would not have wanted to hear that. And that might have been a time where he was like, I'm not ready to talk about that information. And so we do need to be sensitive to, as a medical team, being able to meet everybody's needs and provide information at different times to different people depending on where they're at in their process. And so I hope that we continue to get better about making that information gathering more open along the way of someone's serious illness, so the people they love can access the support and information they need along the way.
Mhm. We've talked about advanced directives and we've talked about kind of the very end, but really there's usually a long journey to that end. And that's where we can talk about hospice and palliative care. I know you work in those fields. I guess, could you first start with explaining the difference between hospice and palliative care? I think the distinction between the two doesn't exist for a lot of people. They think palliative care is hospice or vice versa. Uh, can you just explain better what are those two things? How do they differ?
Yeah, and that's a super common question. And those words have a lot of meaning to a lot of people. Palliative, it's a weird word. It's not something we say all the time, and so it's hard to spell and pronounce. I say it every day, but most people don't. And so palliative care, palliative medicine, seriously, all that is it is medical care that is focused on quality of life. That's it. And it therefore can and should be offered and delivered for anyone dealing with a serious illness, really at any point, whether their prognosis is 10 years or 10 months or 10 days or 10 hours. It's just quality of life focused care. And what quality of life means, though, is not only, I'm the doctor part of our palliative care team, so of course I'm super into the symptom management and what I can prescribe to help somebody feel better. And maybe those things I prescribe will help them be able to tolerate a surgery better or more cancer treatments better, or other things better so that they live better longer. But just as important in that quality of life focused care of palliative care is there is a lot that we deal with as patients and families, with emotional and social and spiritual issues while we're dealing with a serious illness. And so that's why palliative care, and I'm always talking, it's very team focused, and it very much depends on having physicians and nurses and nurse practitioners and social workers and chaplains as part of the team to make sure that we truly are trying to take care of the whole patient and family.
So how do I get a Dr. Mavity to be on my team and
Yeah,
provide palliative care? What's
yeah.
the trigger for that kind of care?
The trigger really can be the thing that instigates a consult generally for us in the hospital setting would be is someone who is struggling with symptom issues or their goals for their medical care. And so as much as we can do that advanced care planning, the advanced directive, and think about what I would want, if there are times in the hospital and also outside of the hospital where there's a decision point where I can choose this or this, and it's not always clear. And so a palliative care consultation can often be helpful with really an objective, like talking through what are our options, really helping that person to focus on what's important to me, and then helping to make sure that their medical choices really meld completely with their quality of life choices. And so that can happen in the hospital, and generally lots of patients and families will ask for it, and lots of the physicians and providers in the hospital, nurses and chaplains will bring up, hey, this person's struggling with their goals of care. Maybe a consult would be helpful. And similarly, in the outpatient setting, primary care providers or specialists might notice that one of their patients is struggling with a serious illness, and they want them to have better symptom management, or they want them to have help with making good decisions for themselves. And so that's often when we'll get pulled in. And so we really think about palliative care as being pre-hospice. It's kind of pre-hospice. Hospice and all hospice is palliative care at a later stage of illness. And hospice is set up as a service, and it's defined basically by Medicare and insurance companies for as being palliative care, still team-based, still super quality of life focused, but for when a person's goals are comfort focused, and when they're generally home-based and comfort care focused. And that'll often be at a time where curative or invasive treatment options are no longer either attractive to that person, they don't want to do those things because they don't provide a quality of life that they find acceptable, or we don't have those options. And I am constantly saying, I hate it when we as providers say, we have nothing more to offer. Oh, no, 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 no. We've got more to offer for sure. Even if we can't fix or cure someone, we can always provide comfort if we can't do that. And so we always have more to offer, but sometimes we do run out of life prolonging options that can work.
Mm-hmm. Dr. Mavity, I'm going to ask you one more question, and then I want to start getting to some of these audience questions. But I'm curious, you work in such an interesting field. In your many years of doing this now, what would you say has been your biggest learning or the biggest surprise? I mean, when you leave work, do you have that moment where you're like, wow? I mean, what is that moment for you in this line of work?
I do think that probably the biggest wow is it's impressive how strong human beings are. I have seen people who emote a strength that is unfathomable. To try to stay alive for someone they love, to be strong enough to be able to say goodbye when it's time. The strength, the strength that we inherently have as human beings, and our adaptability and our ability to really persevere and to find quality of life in small ways, even when we're being robbed of it sometimes because our bodies are falling apart, is that's a big wow for me.
Mm-hmm. Thank you. That's a great insight and answer. I just think it's such interesting work that you do and such special work. I have to say that. It's special work. Before COVID, and I was still wandering the halls of the hospital, we'd hear that chime, that sounds when
Yeah.
there's a new life or there's a death. And I'd always wonder, was it a baby being born or did someone pass away? And it always made me feel very privileged to be at the hospital when those moments happened, to know that I work in this place where this circle of life happens. And so I admire what you do, and I think it's very important work. And I thank you for doing it. It's really interesting. And
Thank
now I
you.
can't hog you anymore. I have to share you with the audience. So we've got some questions coming in. And the first one is, how do I get the right questions to talk to my family about advanced directives?
Great question. I have a resource that I would strongly recommend. It is also on our Advanced Illness Management website. It's the Conversation Project, and some really brilliant people at the IHI, the Institute for Healthcare Improvement, in partnership with a really amazing columnist, Ellen Goodman, put together some materials to help people have those conversations. The Conversation Project is exactly that. It's actually a public media campaign that's all about having the conversation at the kitchen table rather than the ICU. And they've got just some super great tools that are, it's totally free. You can get on the website, you can print off the materials, and they're great tips to start those conversations with family. It asks you things like, is it more important to me to be able to, be independent, or is that less important? Is it really important for me to be pain free or to be alert and able to interact really well with the people I love? It starts to ask some of those questions, and it starts to get the cogwheels rolling a little bit and thinking about, okay, how am I going to talk about this with my loved one? So I think that that's a great tool. There are other tools out there. There's one called Five Wishes that encourages folks to really think about what's important with them. And there's an Oregon Health Decisions. We have that booklet at St. Charles sites that has actually like 20 pages of workbooks to think through different illnesses about what you want. So there are lots of tools out there. And I think, as much as this is medical, there's a lot about it that isn't medical. And it really, while getting guidance from your medical team is really important than this is about you. So it's okay for it to start non-medical. It's really okay for it to start really focused on life and living, and not the machines and things that we do in the hospital. And so it's okay. I think, for in medicine, people who aren't part of the medical thing, we call them, lay people, and lay people own this. This is yours. This is your life. And our job is to give you the information so that you can make educated decisions. But they are yours, and we need to honor people's wishes. So it should really start at the kitchen table rather than in the ICU.
Right. Well, I'm glad you brought up the Conversation Project. Ellen Goodman, St. Charles brought Ellen Goodman to Central Oregon a number of years ago to talk about this very topic. And she did point to that website in that project as a great resource for these kinds of materials. So thank you for bringing that up. The Conversation Project, check it out online. They have done a lot of really great work to make this easier and to give you those tools that you might need to walk into a Thanksgiving dinner and start having this conversation. Next question from an audience member. Could you talk about why this is so important now in the age of COVID-19?
Yeah. Boy, COVID has changed our world. Whew, hasn't it? Living in the time of a pandemic and practicing medicine in the time of pandemic has been really interesting. COVID has put an extra layer of really thinking about the importance of what I would and wouldn't want. It's just that extra layer of seriousness, and it's now. It's really, I think, pushed a lot of us to really think about what they want for their invasive medical care, in that COVID makes us terribly ill, and it is not. And what happens, it's not uncommon for people to end up in the hospital if you're one of the percent who ends up getting really sick with it, and it's not uncommon to end up in the ICU on a ventilator. And so I think that for folks who are living with serious illness, knowing that those unfortunately are the ones who are more likely to get terribly ill with COVID, because the more medical comorbidities that we have, the more likely it is that you're one of the unlucky few who gets terribly ill with this. Has really pushed people to think about, if I get this, do I really want to go to the hospital? If I get this, do I want to go to the ICU? Do I want to be on a breathing machine? Is all of that okay with me? I think a lot of people in our community and nationally have put some thought into that, and have drawn some lines in the sand about whether they would want to go to the hospital or not, or whether they would want, really invasive artificial life support or not. And so COVID really does bring this to a head for us.
Hmm. Yeah, it certainly does. A comment from one of our viewers. I really appreciate the two different scenarios that you offered about two people and their dying experience. They're an example of the benefit of taking the chance of having the conversation versus the consequences of not having the important conversation. Thank you, Dr. Mavity. I'm so grateful to work with you. So, one of your coworkers at the
Yeah.
hospital. Another question: if a patient doesn't want to be kept alive, but the family does, how do you advise them in that situation?
Oh, that's a common reason for a palliative care team consult. In that, part of what we very much at St. Charles, and I think all health systems, is we want a consensus. We want everybody to be together, and these are really difficult decisions, and so a consensus is really important. The general way we would approach that, especially if the patient is able to speak their wishes and is able to say, no, 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 I really don't want to do this, but the family's like, no, we absolutely insist. Is that's what I do, as a member of the palliative care team, is we do family meetings. That's what we do. We all sit down, and the hope would be is to really help, the patient and their loved ones and the medical team really voice their thoughts about it. And usually, what'll come out of that will be things like, the patient will say, well, I don't want to be a burden to my family. And the family will say, no, 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 you're not a burden. We want you to live. And so those are usually the things that'll come out of a scenario like that. But it does take just sitting down and bringing forth everybody's thoughts and concerns, and then working through them together. And so those aren't usually solved quickly. But we are all, it's really important to honor what patients want, but we really want to make sure that everybody understands where they're coming from and why they want what they want. And then it usually goes a lot easier for everybody.
Hmm. Great. If What happens if someone doesn't have the conversation? Who would make decisions for me if I can't make my own decisions and I didn't complete an advance directive?
In the state of Oregon, there's very clear Oregon statute that designates, if someone has not completed an advance directive and they haven't designated a surrogate decision maker. We actually have a legal list that starts generally with their spouse, and then I believe it's adult children, and then parents, and there's a whole list. And so if you don't have the conversation, you're up to the legal folks. And sometimes your spouse is not the right person to be your surrogate decision maker. A lot of times your spouse is. That's who probably knows what you want best, and you probably share a lot of the same values, which is why you're married. And so that usually works pretty well. But a lot of people will designate someone else who they know, and they can say, you know what, this would be way too hard for my wife. I know that this is too much pressure for her to be able to be my voice, so I pick my cousin. And then they complete their advance directive, and then we know, that's the person to go to. While of course we're supporting the wife as well if we're making difficult decisions.
Hmm. Okay, great. If a patient agrees to hospice or palliative care, does that mean they're giving up?
That's a really common concern, and it kind of gets back to that whole American battling the foe, right? And then the giving in to the enemy, which is death. We really try to help refocus that on, we all are born and we all die. And so death, I mean, it happens to each and every one of us. Is it really a foe? Or is it, and can we reframe it that I want to live as well as I can every day that I can? And so when someone is contemplating really pursuing palliative care or hospice, that frame shift on, hey, this is about making every day as good as possible. One of the things that's been very exciting for us in the hospice and palliative care field was a study that came out 10 years ago that I quote all the time about how some folks who were dealing with really serious advanced stage lung cancer who had usual treatment as compared to having palliative care consultations and support through it. The group who got the palliative care, in addition to regular treatment, lived 3 months longer than the folks who didn't. And so I think there are a lot of ways we can say, hey, that choice for home, that choice for quality of life, that choice for comfort isn't giving up. Sometimes people live better longer when they're home.
Hmm. That's a good point. Yeah, thank you for bringing up that study. I've read something in other books and literature too, so that's a great point to make. How does your job as a hospice palliative care MD change the way you look at life?
I think really getting to work with folks in this profoundly intimate time and getting reminded every day how short and precious life is has really I've actually kind of likened it to kind of a spiritual practice that I get forced every day to admit my mortality, the mortality of the people I love, because the patients and families I get to care for gift that to me. They, oh yeah, don't forget. No, it's going to happen to you too. And so that has really been a really special thing to be reminded every day to tell the people you love them, to make sure that you truly are doing what you love as much as you can, because time could be a lot shorter than we're hoping or that we think it is.
Mhm. If I receive palliative or hospice care, will I still be able to see my personal doctor?
Great question. Yes. And so the nice thing about hospice and palliative care is you kind of get to handpick your team. For most of us who are receiving hospice and palliative care, we always still need a quarterback. And I like football, so I call it a quarterback. We always need that one provider on the medical team who's kind of, yeah, really coordinating how everybody works together. And that for most of us is our primary care provider. That's usually the one who kind of has a pulse on everything. And so you don't give that up when you choose hospice or palliative care. Palliative care is really just an extra added layer of support on top of, your medical team. So your primary care provider is certainly still crucial to your care. And then on hospice, what we really like to see is that at that time, when someone's prognosis is limited to weeks to months at that time, or even shorter, a lot of us don't want to waste our time going into the doctor's office and going to doctor's appointments. And we generally have limited energy at that time. While you're totally allowed to, we like to have the hospice team really be the eyes and ears for the primary care provider so that they still know what's going on. They've known this person for many years and have probably cared for their serious illness through it. And so having their perspective again continues to be really crucial to the medical team, but that the choice is for the patient. Then you can go see your primary care doc, you can go see your primary care provider, but you don't have to. Your hospice team can be the eyes and ears and coordinate and make sure that they have input about how things are going for you.
Great. We probably have time for just one or two more questions. What do you tell patients who are fearful of dying?
When folks tell us they're scared of dying, well, first of all, that's really common. Death for many of us, a lot of us have a very strong faith, and so have some faith and belief and have a knowledge of what will happen to us when we die. Others of us may have a less defined one, and some people might not have a belief in an afterlife. We're all really different in that. But no matter what someone's belief system is and what their faith is, it's an unknown still. We can have a strong belief, this is what I know will happen, but you kind of don't know till you get there. And the whole fear of mortality for most folks, some are fearful about what happens after they die. Most people are actually fearful of what's going to happen between now and when I die. That's the scary time where your body's doing things that your medical team can't control anymore. That's why you're dying, is your medical team, it doesn't, they're not able to change how these natural processes are happening. And so we really try and talk with folks about, well, what is it that's scary to you? Is it a loss of independence? Is it a worry about being a burden? Is it fear of pain? Is it fear of anxiety? Is it fear of the afterlife? And then no matter what that is, that's kind of their primary fear. Then if we're lucky enough to get to talk about those things early on enough, we can often bring some comfort and resolution in really helping people wrap their minds around what's happening to them and where they're going, helping them with some legacy work, helping them to do the things that most of us want to be able to do before we die, which is, tell the people you love them, ask the people you love who you've hurt in your lifetime for forgiveness, a lot of thank yous. Those are the kinds of things that we all kind of hope to have that time. And so in talking about that fear of death and helping people with doing that work, that some of us have time to do before we die, can be really transcending for folks.
Dr. Mavity, one of our viewers had asked, how does your work change the way you look at life? I'm curious, how has it changed how you look at death? Are you personally more or less afraid of dying, or do you view it differently because you are so near it?
I definitely, just getting to be with people as they're getting close to death, it is an interesting time. I don't think I'll like not being in control of everything that's happening with my body. I think that's really hard for a lot of us. But I definitely, there are some things that I see. I see people as they're getting close to death. Many of us will see loved ones who've died before us as we're getting close. And I'll tell you, that brings me a lot of comfort. That brings me a lot of comfort that maybe I'll get to see some of the people, who I've lost. Maybe I'll be getting to see them again.
Mm-hmm. Looks like we have another question from a viewer. Can a healthcare proxy or medical power of attorney override the things specified in a patient's advance directive?
Oh, that's a great question. Oh, that's a smart one. The advance directive is so specific. It lays out just very specific scenarios. It is profoundly rarely that a person's medical situation matches those scenarios identically. And so we actually count on the surrogate to be able to talk through the nuances of that with us. It's just so rare that our bodies do exactly what's laid out in the advance directive. Our hope would be is that the surrogate's intent is to honor those wishes, but they might have had a specific conversation with their loved one about, well, I know they said they didn't want to have, artificially administered nutrition in this situation, but let me tell you about what they were really thinking when they put that down. And then we kind of work through it together and again, come to an understanding together and then a consensus moving forward. So they can, but it's generally not with the intent to go against their loved one's wishes.
But you raise a good point that the advance directive is not all inclusive. It can't be, right? There's too many unknowns during that stage of life. So it really underscores the importance of having that conversation so that surrogate can fill in those gaps and help you understand those nuances, which may not be evident in that advance directive.
Exactly.
Great. Well, Dr. Mavity, I think we're just about at our time and we have gone through all of our questions. I just want to thank you so much for sharing your time with us this evening. It was a really thought-provoking conversation, and I hope that those who are with us tonight can think about how they might approach having that conversation with their loved ones. At the very least, as a first start, get online and go check out that advanced directive on the Oregon Health Authority website or on the St. Charles website on our advanced illness management page. There's some other good resources there. And also, as Dr. Mavity mentioned too earlier in the program, the Conversation Project, great place to get more materials. So if you're thinking about this, definitely take the time and research it. And if you have questions, perhaps we can circle back and address those at a future Doc Talk. So thank you so much for joining us this evening, Dr. Mavity. Thank you once again. We appreciate your time. We hope this has been informative and interesting, and we'll look forward to seeing you back here again in November for our next Doc Talk, where we're planning to talk about cancer prevention. So until then, be safe, be well, and we hope to see you here again soon. Good night.
Good night. Thank you.